I see Obamacare has brought out the best in us. You notice the enrollment is somewhere between Halloween and Pearl Harbor Day. I'm just tossing that out there. Okay. We received several questions about what happens if you are underemployed, unemployed, or barely employed as far as the coverage under Obamacare. So could you guys comment on what happens to the underemployed person and their ability to pay for these plans, and or the people who are unemployed and have no ability to pay for these plans?
Yeah, I was speaking to someone during the break about this. Really, we don't know what the prices are going to be, but the example that the IRS gave us was that $21,000 premium for the lowest plan option for a family. So I would assume, but I shouldn't assume anything, that the single rate will be about $10,000 to $12,000 a year for an individual. Some individuals can go on healthyny.com and try to apply for coverage.
We received some questions about defining the bronze, silver, gold plans and what those really mean, and are those same plans going to be applicable to Medicare and things like that?
No.
No.
No. They're not going to. Similar to Medicare? Is
Are they
that
going to be available on Medicare? Is Medicare going to have gold, bronze, silver things, or is that only in the exchange?
No.
Okay. Those are some of the questions that we received. Brian, any other pharmacy questions? No. You guys shot Brian down. He's afraid to ask anything.
I'll go.
Yeah. That's basically the groups of questions. I'm a little hesitant to open it up to the audience here. Before we do that, we do have some Kevlar vests for the speakers here. Maybe we should don them, and then we'll, why don't we open it up to the audience? Because again, I tried to group them, but there may be some individual questions. Yes.
Questions?
And again, one second. We can't get into specifics. We had a bunch of questions of, my premium is this, I'm paying this, and that. This is not individual, let's figure out your premium kind of thing here, all right? So let's keep the questions general.
In general, it's related to premium. I happen to notice that in the past 5 years, the premium in Medicare for a managed plan had gone up 400%. Was that because the insurance companies, in anticipation of what was coming down the road, were they trying to get as much as they can now because they were afraid they'd have to cut later, so they were trying to, take as much money as they could now?
They can't. The way that premiums are set are based upon actuarial data. I mean, they can't just, in New York, I know for sure, I worked for a health insurance company, every year on renewal, they have to put forth the amount, like Aimee talked about, medical loss ratio. If they paid out 90, 95% or over 100% of the premium it took in, obviously they got to increase the rates. So it's based upon data. The regulators are not going to just allow a company to just pump up the rates and charge the consumers. And matter of fact, when commercial insurers put in for a 20, 25% or 50% premium increase, even if they can document it through the underwriters, the insurance department, used to be the insurance department in New York, now it's the Department of Financial Services, they'll knock it down. They won't allow it.
The HMOs, the PPOs, will that be in existence?
The question was, will the HMOs and PPOs still be in existence?
Yes. That's not going to change. There'll be more plans with deductibles now. You're not going to see those traditional type of copay plans out there anymore. Just a flat copay, depending on the size of the group, I should say that. But there'll be more plans with in-network deductibles.
Do you have any idea why they changed in 2013 the HMO, PPO, PPO1, PPO2 had changed with a lot of the insurance, with the Medicare Advantage plan, where Nassau County was part of these plans, now have been taken out and limited now where Nassau County fits in. Nassau County had more choices. And I'm talking about like Emblem.
Yep, it has to do with the subsidies they get from the government, basically, to offer these plans. And a lot of those subsidies have been cut. So they just don't, they pull the plans or they pull the territory right out.
Yep. Tie-dye, purple.
How can they implement Obamacare if it's not even completed yet? Hasn't figured everything out yet?
The question is, how can they implement Obamacare if they don't have everything figured out yet? This is the. Have you been to the post office or the motor vehicle department?
I don't think they've even read the whole law.
So, you want to take a shot at that, or?
I think that's kind of par for the course. And the law is how many pages in that? Thousands of pages in the law. I don't think they even realize the unintended consequences of what they were writing, to be quite honest.
Does this new Obamacare cover all of the people in the United States, including the people in Congress who passed this law?
That's a great question. And they are exempt. They're also exempt from insider trading laws.
She wanted to know if everyone in the United States will be subject to Obamacare, including Congress and the Senate. There appears to be a resounding no.
I will say that they're exempt, and believe it or not, some unions are exempt. There's some unions in particular that are exempt from the law, and the Amish are exempt. There's some groups that are exempt from the law. The union, what I mean by that, I have a few groups that they have, their employees, and then there's union employees. But if the union plan doesn't meet those requirements, the 9.5%, the affordability, it's the employer that has to pay the fine and get the penalties, not the union. That's
generally, since some of us are getting older.
Since we're all friends here, yes. I'll repeat it as soon as she tells us.
Is Medicare in general going to be decreased, what's given to people, because Medicare is going to be, I've been reading, to be used to fund all the other components of Obamacare, Medicaid, Obamacare, state.
Hearing about Medicare benefits?
Yeah, is Medicare.
The question is, will Medicare benefits be reduced in order to pay for all of these other plans, policies, and everything else?
I have read some articles that some benefits will be cut from Medicare over the next couple of years, but I don't know. I've been getting emails from groups and asking me certain questions and sending me articles, so I'm actually having legal really find out what the truth is on that. So it's probably somewhat true, but I don't know what. What were the benefits? I'd have to look, but some of the benefits as far as medical devices and having a certain age and not being able to administer chemo or physical therapy at a certain age. But I don't know if this is true or just propaganda, so I'm not going to comment until I really know what it really means.
My understanding that this law is designed to provide health access or insurance access to all the citizens of this country. In the area of first responders, though, and emergency room personnel, what do we do with people who fall through the cracks? How do we get them to be responsible? Like, for example, undocumented aliens, people like that. Is there any provision in all of this that will provide for coverage for those people?
I think page 1503.
Yeah,
No.
I know.
Did you read that? Right. Any comments?
I believe in California they have included them. I believe in California they included the undocumented workers, but I don't know if that's going to be included here. I'm not sure.
Those individuals are going to still seek their coverage through the emergency rooms, and the hospitals just it's against the law to turn them away. And the hospitals are compensated for care that they don't get paid for, indigent care pool. So the state and the federal government, they part of the taxes that are assessed come back to the providers of care when they're, especially hospitals, when they can demonstrate that they're providing charity care.
Just to give you some quick background, from a hospital point of view, many of the hospitals in the area and around the country are planning for the future as best we see fit, and a lot of the hospitals are planning to largely expand their emergency rooms in anticipation of a lot of walk-in type care that's going to be rendered, that a lot of the physicians are going to be unavailable. A lot of offices are going to be unavailable or closing down because of this, and the emergency rooms are going to be swamped. They're also cutting back on the number of hospital beds with the assumption that length of stay will be driven down and that the insurance companies are not going to be paying for a lot of inpatient stuff, and a lot of the things that are now done inpatient are now going to be done as an ambulatory or one-day type stay. So the hospitals are gearing up for a tremendous change in how healthcare is delivered once all of this goes into effect, and it has a huge financial impact on what happens in medicine. So just so you guys see it from a hospital point of view of we're gearing up for a whole other side of this.
On the heels of the gentleman's question, what about tourists? Because there are millions of tourists that visit here every year. There are some countries in Europe that require you purchase a healthcare insurance prior to visit.
Right.
Is there any provision for tourists?
The United States will be banning all tourists from ever coming here. We figure it's the easiest way. Unless you come in with an undocumented worker, then you're allowed in. Anything?
No, there is no provision for that.
Nothing. We don't know anything. There's nothing in the first 2,000 pages about tourists. Once he gets to the second half of it, there may be something in there, but nothing we know about. Way in the back. You're about to explode. Yeah, you're in blue. Jump up.
For those of us in the category under 65, I'm a little confused. They don't qualify for Medicaid because I think when I checked it online, you can't have more than so much money in the bank. But I'm confused with like the poverty level. If you could explain further about it. If you spend $10,000 a year, how you get subsidies. I mean, I'm just a little confused by that.
They haven't come out on the regs on what the subsidies are, but I know they're expanding Medicaid, and that's what some of the taxes and penalties are. And I think it's about 400% of the poverty level that you can now get Medicaid. You will be able to apply for Medicaid, and I believe that's about $47,000 a year.
See, had you invested in the stock market, you'd now be eligible for Medicaid. So it's just poor investing on your part.
Right.
So, yes.
Our private doctors who have private practices or group practices that were on their own are now throwing in with Winthrop.
Yes.
Is that because of Obamacare? Is that going to help with Obamacare?
It's not specific. Well, it's not just Winthrop. It's, many of the private offices can no longer exist under what's going on, and it will get worse. And a lot of them are merging with hospitals or larger institutions in preparation for this. I know people were asking before about physician's assistants and things like that. Just to give you an example, okay, when we do a joint replacement, you are paid one global fee for the pre-op visit, the surgery, and 90 days of care after that, okay? That fee formally was about somewhere between $5,000 and $8,000 to the physician for that, okay? Keep in mind our malpractice insurance is approximately $125,000 a year per person. So if you have 5 people in your group or 10 people in your group, you do the math on that, all right? So a fee was between $5,000 and $8,000. The Medicare fee, which most of the patients over 65 are, and that's who's getting these replacements, is about $1,200. So immediately our cost went from $8,000 of reimbursement down to $1,200. They're talking about basing this on Medicaid fees. The Medicaid fee for hip replacement is $300. Okay? So you divide $300 into $125,000, and that's just to cover your malpractice. That doesn't include putting the lights on, paying your employees, maybe eating, and possibly going to a movie. All right? So there's no way that you're going to survive in this environment if it comes to that. And that's why these offices are trying to align with hospitals who may be getting some reimbursement for the hospital stay and things like that. A physician's office visit, say it's $200 or $300, all right? The current rate with the current plans is approximately $80 for an office visit. The Medicaid rate for an office visit is $7. All right? So that's why people are saying, why am I going to see the physician assistant? There's no way you're going to be able to keep that office going at $7 a pop, or even if it's $12 or $13 a pop, paying the insurance and everything else. So the only way you're going to possibly do it is high volume. And the only way to do high volume is to have multiple people seeing patients, and you're kind of supervising it. So that's why you're getting a change in who you're seeing, why your doctor's spending 14 seconds with you, why there's PAs all over, why we're aligning with hospitals and things like that, because you're not going to survive in a practice situation with these kind of rates and reimbursements. So if that explains any of it, but that's what's going on there. Yes? If you want.
Okay, I'm still unclear. If somebody's been on Medicaid and Medicare for a number of years, they have a 3-day-a-week job, minimum wage, used to be in academia, not anymore. Okay, can I replace my Medicaid, Medicare with some form of Obamacare that I can afford, which will either through a group plan if my employer is required to supply me with one, or an individual plan that I can afford that will pay the doctors what they want, not what the government wants. So if I can get what I want, that's what I'd like to know.
Well, you're talking about boutique medicine, in a sense, of paying the doctors what they want. Right. He's asking about will there be plans available to pay the physicians what they want, which probably going to happen, as it happens in other countries that have gone to a national healthcare system, is you often develop a 2-tier system or a multi-tier system of physicians who say, I'm not taking any of this, you want my services, here's my rates, pay them, or you're in this other plan where the rates are set, the reimbursements are set, things like that. That's what's happened in other countries.
I would have to get rid of my Medicaid, Medicare, or I could stay on it and then pay into another plan as well.
There may not be another plan, but you can stay in your Medicare, Medicaid if you want to see the doctors who subscribe to that. As Chris pointed out, there'll be certain doctors, or Aimee pointed out, there'll be certain premier doctors who take that, and then there'll probably be another set of physicians, hospitals, whatever, who say, we're not taking any of that, you want these services, here's what anesthesia costs, here's what the surgery costs, here's what the implant costs. There are countries where you actually go out and buy your own implants, bring it to the hospital and say, put this in me. Okay, so
Qualify for any group plan or individual plan that the government might subsidize under Obamacare simply because I'm on Medicaid and Medicare. Is that what you're saying?
no, I'm saying that there's going to be most likely multi-tiers of medical delivery depending on what you want to pay. Probably. That's what's happened in other countries that have gone to this. Okay. Someone's exploding in the back there. Purple, yes.
Will it be like in some other countries, depending on the type of surgery that you need, that there will be a waiting list? You have to wait until your turn?
Most likely, yes. Because the regulations are getting more stringent. As Chris pointed out, they're going to come down harder. You know, even in the last 6 months or so, the government has stepped into, if you come to the office now in need of a hip or knee replacement, a year ago I was able to look at your x-rays, evaluate how you're doing, assess how you're walking, assess how much pain you're in, and schedule you for surgery, okay? The way the current law is written now is that if I don't document that you have already been on multiple medications, had physical therapy, tried injections, tried bracing, and document that all of these things happen, I can't even schedule you for the surgery, or I can be penalized and lose all the reimbursement for that. So these restrictions, as Chris pointed out, are going to get more and more stringent, and there's going to be a lot more hoops to jump through. The current waiting list in England right now is about 3 years for a hip replacement. I tell my patients they have to wait 3 months and they want to shoot me. So I don't know what's going to happen when it goes up to that, but it probably will.
I want to know if they come in and the physician's assistant diagnoses. Is she the final say? No. Or does a doctor check it over before?
It depends on the situation. If it's, if it's something very straight, I know with my physician assistant and with the other ones in our office, they see the patient, they make a diagnosis. If it's something relatively straightforward, almost always if it's a new patient, they will bounce it off of the doctor and say, here's what I saw, here's what the patient has, here's what I think is going on. Most of the time, we let the physician assistant see the follow-up patients who they know for a long period of time. The diagnosis has already been made, and they're doing the post-op checks and things like that. But if there's any question, that's why the doctor is overseeing these physician assistants, and they bounce that off of them. That's the way it's supposed to work.
We're to be told, and I may be mistaken, with the passage of Obamacare, that our costs, medical costs, that is, would be reduced.
Prior to November, yes, you were told that. Yes, none of these numbers were available before November.
Can you repeat the question?
Question is, weren't we told with the passage of Obamacare the costs will be reduced? And that was actually Chris's opening statement, that, if you remember his opening statement, was exactly not that.
Yeah, I mean, Kathleen Sebelius, the head of Health and Human Services, continues to say that eventually the cost will go down. It's not the case.
See, this is what happens when they don't pay for psychotropic drugs. They continue to say things like that. So, yes. Question?
Yes, I have a question. What is the Winthrop community going to do? You already answered part of the future. What are you going to do at this present time to help to facilitate not just the patients, the doctors, the whole community in order to get through Obamacare? It's not just the whole community, not just us, because I don't care about just us. I care about you too.
The question is, what is Winthrop doing to prepare for all of this? We're taking it in stages. We're trying to deal with what the patients need first. We're trying to, as someone pointed out, align the private physician offices with the hospital. We're planning structural changes, as I said, with regards to emergency room size and things like that. So it's a combination of patient care, physician alignment, and facility management to prepare for this. But as everyone's pointed out here, there's a huge unknown to all of this, so we don't exactly know what we're preparing for yet. You know, nothing is, every time a deadline comes up, it keeps getting pushed, so we don't know who's coming in. You know, another part of this that we talked about is you're talking about another 30 million people coming on board. The government is also cutting back on reimbursement for physician training. So in addition to these people coming on, they're cutting back our ability to train more physicians, and we're going to wind up with more people retiring, more people just throwing their hands up in the air and saying, I can't afford to practice anymore, and we're having less people training. In addition, no matter how you look at it, when people graduate college or in college and are looking for careers, without question, financial reimbursement is a big part of career choice. And if you keep driving down physician reimbursement and things like that, people are going to say, you know what? I'm going into business, I'm going to stock market, I'm going to whatever. I'm not doing medicine. I'm not doing 4 years of college, 4 years of medical school, 5 years of residency, 1 to 3 years of fellowship, getting out when I'm 31, 32, 33 years old, owing $500,000, $150,000 a year of malpractice to make $7 an office visit? Not happening. I'll go into something else. So that's further going to drive down who's going into medicine. Way in the back.
As long as I can remember, there's always been a certain amount of the healthcare bill in the United States that was caused by such things as overtreatment, duplication of treatment, bad medical practice and so forth.
Right.
I understand that the Obamacare is attempting to deal with that issue. Can you elaborate on that a little bit?
What's that? Right. Basically, if you look at reimbursements, the government is going, and all the insurance companies are going for fee-for-service to value-based service. So instead of paying for service rendered, they're going to pay for the value of that service. So if you have a procedure done, in the past, if 20 people had a procedure done, you received 20 paychecks for that procedure. Now they're going to look at the value of that procedure and say, you did this procedure, but 10 of them were screwed up. We're not paying for those 10. They're paying for value, all right? So that's part of it. The other big part of it, of duplication of services and tests and things like that, unfortunately have to do with the whole litigation system in this country and what's going on with that. And if you look at why many of these tests are ordered, it's called CYA medicine, it's cover your ass medicine. I'm not taking the chance that knee pain you have is not a tumor. I better get an MRI. So that significantly drives up the cost of medicine because you're constantly ordering tests just to cover yourself. And a lot of that would be obviated if there wasn't a lot of the litigation hanging over why we're ordering tests.
So they're not addressing that issue?
That issue is not being addressed at all. In some states it is, but in New York it's certainly not. Let's do one more question and then we are out of here.
Okay, I have a Medicare, but I also have a plan for a retirement plan from where I work. When it comes here and I get the pension and I go through their medical plan as my secondary. Does that involve the New York exchange, or is that through Illinois?
Yeah, you have a secondary coverage through your past employer where you're retired, and you have, right, now is that self-insured plan or is that fully insured? Who is that through? Is it through the employer?
United.
United, so, yeah, it could be, and it's always the question, whether it's going to be, go through the exchange. You're not going to have to go through the exchange.
The Illinois laws, or would that be through New York laws?
It's where the company is based. Those are the benefits. The benefits are based in the state. The state regulates the insurance, the coverage, so it's based upon that. Thank you.
Thanks. Listen, no. I hope you enjoyed this. I hope you also get a feeling that there's a lot of stuff that's still not understood about this, as you heard from the questions tonight, from the answers, from some of the disagreement. So we'll see what happens in the years to come, but I hope this gave you some information or some basis of where to start with this. Thanks. And thanks to the panel and the speakers.
Thank you. Thank you. Thank you.